Hi everybody, my name is Carlos Sierra and I am a medicine student in the Catholic University. Well, the topic I am going to talk about is the therapy in adults with tuberculous meningitis. Well, tuberculous meningitis occurs when Mycobacterium tuberculosis invades the membranes and the fluids surrounding the brain and spinal cord. The infection usually begins elsewhere in the body, usually in the lungs, and it travels through the bloodstream to the meninges, where small abscesses are formed.
Tuberculous meningitis. Meningitis due to tuberculosis. Tuberculous meningitis is the most severe form of tuberculosis. It causes severe neurologic deficits or death in more than half of cases. The pattern of tuberculous meningitis in the population is different in different areas of the world. In areas with much tuberculosis, tuberculous meningitis usually affects young children. It develops typically 3 to 6 months after the primary tuberculosis infection. By contrast, in areas with less tuberculosis, tuberculous meningitis tends to strike adults. It may follow the primary infection, but, more frequently, is due to reactivation of an old focus of tuberculosis that had been dormant, sometimes for many years. Tuberculous meningitis begins insidiously with a gradual fluctuating fever, fatigue, weight loss, behavior changes, headache, and vomiting. This early phase is followed by neurologic deficits, loss of consciousness, or convulsions. A dense gelatinous exudate outpouring forms and envelopes the brain arteries and cranial nerves. It creates a bottleneck in the flow of the cerebrospinal fluid, which leads to hydrocephalus. The development of arteritis and infarctions of the brain can cause hemiplegia or quadriplegia. A high index of suspicion is essential to diagnose the disease because early diagnosis is the key to a satisfactory outcome. If tuberculous meningitis is seriously suspected, treatment should start immediately. Treatment involves chemotherapy to control and eradicate the infection, management of hydrocephalus and elevated intracranial pressure, and immunomodulation with corticosteroids, cortisone-like drugs such as prednisone. The World Health Organization recommends a 2-month intensive course of isoniazid, rifampin, pyrazinamide, and ethambutol, followed by 4 months of isoniazid and rifampin. Elevated intracranial pressure can be life-threatening. The hydrocephalus may require placement of a ventriculoperitoneal shunt. The use of the corticosteroid dexamethasone improves survival in patients over 14 years of age but probably does not prevent severe disability.
Well, continue with the pros and the cons. Guidelines generally recommend treatment with rifampicin, isoniazid, pyrazinamide, and streptomycin, or ethambutol, for 3 months in the intensified phase, followed by at the less of the 6-month period of treatment with rifampicin and isoniazid. Antituberculous drugs are known to have variable CFF penetration. In particular, the CSF penetration of rifampicin, the key drug in the TBM treatment, is poor, as is that of ethambutol and streptomycin. Isoniazid and pyrazinamide penetrate more readily. Sufficient is activity of rifampicin is key to successful treatment, demonstrated by the fact that rifampicin resistance is associated with 100% mortality. The cons, drug resistance is a large and growing problem in many TB endemic countries. Mutations can arise in MTB that confer resistance to chemotherapy and can be transmitted as easily as the original strain.
Tuberculous meningitis is a serious bacterial infection of the cerebrospinal fluid, and up to 1/3 of patients die despite treatment. Therapy for tuberculous meningitis is based on data for pulmonary tuberculosis, but the standard treatment may not achieve sufficient drug concentrations in cerebrospinal fluid. The standard treatment consists of pyrazinamide, ethambutol, isoniazid, and rifampin at 10 mg per kilogram per day for 3 months, followed by isoniazid and rifampin for 6 months. In this study, investigators asked whether using a higher dose of rifampin and adding levofloxacin could improve outcomes in tuberculous meningitis. At 2 medical centers in Vietnam, 817 patients with tuberculous meningitis were randomized to receive either the standard treatment or intensified treatment. For the first 8 weeks, patients in the intensified treatment group received the standard treatment plus levofloxacin, with their dose of rifampin increased to 15 milligrams per kilogram per day. All patients received adjuvant dexamethasone. About 43% of the patients were HIV positive. There was no difference between the 2 groups in 9-month mortality rates. 113 patients died in the intensified treatment group as compared with 114 patients in the standard treatment group. And there were no differences based on patients' HIV status. The overall number of adverse events did not differ between treatment groups. Thus, intensified treatment with higher dose rifampin in the standard regimen plus levofloxacin did not improve outcomes in patients with tuberculous meningitis. Full study results are available at nejm.org.
Applications in medicine. Infection is more likely to progress with meningeal TB when patients are confronted with HIV. In HIV-negative adults, the mortality is approximately 25%. For HIV-positive patients is 67%. The British Medical Research Council published a set of clinical criteria for assessing the severity of TB as follows: polyconcision, non-specific signs of mental stage 1, lethargy and recurring and nerve palsy stage 2, stupor, severe alignment, gross paralysis or paralysis stage 3. In patients confronted with HIV, this percentage has high as 40, 52 and 75% respectively. If antiretroviral therapy is initiated in the continuation phase of TB treatment.
This patient has a history of HIV and presented with deteriorating neurological status. Imaging demonstrates multiple enhancing extraaxial, dural-based lesions with extensive brain parenchymal vasogenic edema. There is also an intraparenchymal lesion centered in the left basal ganglia. A brain biopsy was ultimately performed, which revealed tuberculosis. Features that may be suggestive of tuberculosis are the combination of meningeal disease in addition to parenchymal lesions. This represents hematogenous dissemination of pulmonary disease and is associated with a significant mortality rate, as well as a long-term morbidity rate cited as reaching 80% even if successfully treated. Tuberculosis is an important differential diagnostic consideration, particularly in immunocompromised patients or those that are emigrating from endemic areas.
Issue of in Ecuador. In Ecuador, a country with a low prevalence of HIV and related opportunistic infections, a huge proportion of patients begin care at the Tuberculous hospital and complaining of the severe meningeal symptoms could be labeled as probably having TB. And the conclusion, tuberculous meningitis and debilitating and in many cases later form of TB is associated with multiple challenges for both clinicians and research. The major prognostic factors influencing survival and disability include the length of the of treatment initiation, TB and severity grade upon admission, the fear of stroke, seizures, hyponatremia, cranial involvement, serious health, cell count and lateral level, HIV infection and multi-drug resistance.